Good morning, everyone, and welcome to today's PHO webinar presentation, Smoking Cessation and Concurrent Alcohol and/or Substance Use. This is our webinar for National Non-Smoking Week. For those that are less familiar, we observe this week annually in Canada every January since 1977. And we focus and educate people on the health effects of smoking and support people in quitting. Despite the decades of progress, millions of Canadians continue to smoke and are impacted by commercial tobacco use. My name is Selena Degano, and I'm a Senior Program Specialist here at Public Health in Ontario, and I have the pleasure of moderating today's session. I would like to start this webinar by acknowledging that all of us, no matter where we are participating from today, are participating from traditional lands of many nations. I am personally attending today's session from Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to meet, learn, and work on this land. I ask all of us to commit to working together in the spirit of trust, respect, and reconciliation. We would also like to respectfully acknowledge the difference between commercial and traditional tobacco. Commercial use of tobacco is not associated with sacred and/or traditional uses of tobacco, which some Indigenous people have been using for thousands of years. Traditional or sacred tobacco differs from commercial tobacco, both in the way that it is harvested and the way that it is used in ceremony and prayer, often for healing and purifying. Any references to tobacco in today's presentation refer specifically to commercial tobacco unless otherwise stated. So just a few housekeeping items before we get started. So to ensure that we have a focused and engaging presentation today, the Zoom chat has been disabled along with the audio and video features. If you have any questions or comments throughout the presentation, you can use the Q&A function that you can find at the bottom of your window. And we will do our best to address as many questions during the discussion period following the presentation. This session is being recorded and will be shared once it's available in the future. And if you have any technical issues, please email capacitybuilding@oahpp.ca. So without further ado, it is my pleasure to introduce the speaker for today's presentation, Dr. Peter Selby. Dr. Peter Selby is the Senior Scientist and Senior Medical Consultant at the Center for Addiction and Mental Health. He is Vice Chair Research and Gilbon Professor at Family Medicine, University of Toronto. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He uses technology to combine clinical medicine and public health methods to scale up and test health interventions. Thank you so much for being with us today, Peter, and we look forward to your presentation.
Thank you so much, Selena, for inviting me, and it's a great pleasure to see so many people. I recognize some names, and great to be able to share some things. So, without further ado, I'm going to get going into my presentation. My slides will be available to you, but I'm going to take a look at this in terms of, overall, when I'm as an addiction physician, I really look at this as a consumption behavior. And if I can hopefully make these slides move forward again. Yep. Hopefully people are seeing my slides move forward. Selena, I think, let me know. So this is the disclaimer from PHO that all of this has been created by me and my staff at CAMH and does not reflect PHO. It will be published on the PHO website. It's not the owner of the content. And if you're going to use it, please do reach out to me, and we are very open to share. So, and of course, PHO has no liability from using using our information at all. So you heard a land acknowledgement. I too am coming from Toronto, but just in terms of we do talk about land acknowledgements, but I just want to let you know that at my lab, which we call Intrepid now at CAMH, we also have acts of reconciliation, and we're moving towards implementing some of those things. And so some examples are some of the work we've done with working with community using OCAP principles to develop the It's Time resource, which is on our website that can be used for free, can be adapted. It's not a pan-Aboriginal or pan-Indigenous resource. It can be adapted, and we work with a variety of First Nations and Inuit communities to adapt the materials as per their wishes. And then we also have, through the STOP program, collaborations with several Indigenous organizations, and again, have used the options to adapt it to make sure that it fits within the OCAP principles. And then lastly is that we have Shkabi Makwat CAMH, which is a indigenous group at CAMH that really is looking to implement treatment policies, etc. And as part of that, we co-fund evaluators between the two programs so that we can work towards reconciliation. So we're really trying to move beyond the acknowledgement of land, understanding that it's important to do as a first step, but really wanting to start now implementing some of the issues that have been brought up in the TRC. Okay, these are my acknowledgements. Obviously, I want to thank Annika Saiwa, who works with me and has helped prepare the slides. These are my disclosures of grants, research support, speaking engagements. No pharmaceutical funding directly at me. However, as part of disclosure, as you know, we run the STOP program. We go through an open tender process, but the companies that bid on it, now called Johnson & Johnson, now called Kenvue, will provide the medications at discount. And so we just want to declare that as well. No tobacco, vaping, alcohol, or food industry funding. So 4 objectives to get to by the end of this session. One, what are the biopsychosocial determinants of co-use of alcohol and other substances with tobacco and nicotine? Describe the health effects of co-use, situate the role of co-use on smoking cessation outcomes, and then explore concurrent versus sequential treatment of tobacco use in those with alcohol or substance use disorders. But these all tend to be fairly controversial topics. And so let's jump into the first one. Let's understand this issue of co-use. And when we take a look at what is co-use, if you take a look at a prevalence of substance use amongst Canadians aged 15 and older who reported the use of other substances, this is a bit old, but this is published in 2023, but based on 2020 data, you start seeing Canadians who use vaping products. You'll see that it goes, they tend to also smoke cigarettes, and they also tend to drink. And so you're seeing this cluster. And of course, you have a lot of people who experiment with each of those individuals. But the way I've been looking at it is that if anybody is starting out with any kind of nicotine product because of excess, it kind of should be a red flag for us that something else is going to come along. And so when we take a look at Canadians at large who smoke cigarettes, the combustible tobacco, I know we've got prevalence down really low in amongst young people, but for those who are smoking cigarettes, the most common co-use substance is alcohol and then inhaled cannabis, common things being common, legal things being legal. You're going to see that. And then again, with vaping, so people who use the co-substances are obviously inhaled cannabis and alcohol. Interestingly, it's not combustible tobacco. So just keep that in mind. That yes, we talk about dual use, but when we're looking at what is more common, they're using other substances as well. And so when we have, and this implication is for policy, right? So if you think about policies where you have to be age of 19 to get inhaled cannabis, we're thinking of moving smoking up to age 21. These are some really interesting things to look at because I think co-use should be looked at. Young people, especially using substances, we really need to look at it not in isolation, but as a combination. When we take a look at people who are reporting using, vaping is associated with the highest levels of polysubstance use because again, it's concentrated on young people, they're experimenting. People with cannabis also have polysubstance, and almost half are using 2 substances. And again, cigarette smoking is another indicator. So nowadays, if you're seeing young people who are actually smoking cigarettes or vaping, the take home is we should be asking about what else they're using. So why do people use more than one substance? These are the original theories. So one theory is that people are self-medicating, that they're using, these substances to relieve the symptoms of their psychiatric condition, or that's depression or schizophrenia, whatever, or they're trying to manage the side effects, or they're bored, or some sort of self-medication. The other theory is that there's an addiction vulnerability that people have. When we are looking at it more and more, you're beginning to see psychiatric disorders having the same genes, and there's some recent papers that are showing that actually many of them are clustering around 5 vulnerabilities. And so addictions falls under one of the vulnerabilities. It overlaps with that of ADHD, but generally, all of these things, you see a lot of co-use. And so with tobacco policies, you've seen this reduction in the general population. But in general, the people with mental illness have not experienced the same reduction in prevalence as other populations have. And it's complex. It could be that they're more vulnerable to the issues, and it could be also based on environmental factors like the social network, the socioeconomic status, and education. So these are some of the old theories that have been going around of explaining comorbid substance use that you can see they go back to the early 90s. And they still hold true, but no single theory has dominated as to why you see co-substance. But again, the other one is that it's not just genetics, but there are these other determinants that we are beginning to see of adverse childhood experiences that might also be modifying why people use substances. And you're seeing this with the ACE studies and experiences that essentially at early adverse events that there's a score, it covers 10, above 10, you're beginning to see that this may lead to substance use coming into the middle because of some of the impacts that has. And that's in that middle adoption of high risk behaviors. And so might explain why we see higher rates of COPD in people with adverse childhood experiences, because it's mediated through smoking and early death, etc. All of that mediated through substances. Now, when we take a step back and actually now look at where the research is going in terms of what our brains do, our brains have circuits that talk to each other. And those circuits typically have to do with obviously the physiological effects of the drug itself. But more and more important, we're beginning to see that's not just physiology, because when you take a look at a condition like gambling, there's no drug, there's no medication, there's no pharmaceutical product going into the person, but the behaviors are the same. So these circuits that have to do with reward are critical. These are the circuits that have to do with memory, habit, attachment. All these brain circuits speak to each other. And so if that person engages in that binge intoxication colored blue repeatedly, it starts developing habits. In the short term, the person in the red part has the reward, and when they don't get the reward, people keep seeking the reward. But then if you keep doing this, you train the brain to now get preoccupied with it, and now you'll end up having cravings. And so now you get into this vicious cycle that we know that even if you detoxify somebody from a drug, within a year, only 3% will still be abstinent, because it's not detoxification alone, it's these other brain systems that keep the behavior persisting. Now, I like to look at this in a more complex way, that when we are looking at why people do what they do, it is in the moment, if you take a cross section, it's the opportunities and constraints that they find themselves in. But it's determined by their biology, their genetic risks, etc. But those genetic risks have also embodied the environments in which that person was conceived, grew up, etc. So how somebody reacts in a moment is this complex interaction between those opportunities and constraints, their genetic makeup, and how they've embodied the environment. So therefore, some people in the same environment may be less or more susceptible to a substance use, or more likely to recover. And that's why we often say you have to have a combine of generally, conducive environments that make it easier to quit or to move on from unhealthy behaviors to healthier behaviors. But you also have to pay attention to people's individual vulnerabilities that are either biologically determined, psychologically determined, or a combination of the interaction with the environment. So that's the complexity in which any consumptive behavior, and this is the interesting thing, is that all substances, pretty much all substances that people consume have two things. They all often come from a plant origin. They're all consumed. They all have some sort of analgesic effect. And essentially, when you look at the pattern of consumption, they mimic the consumption of food. So it looks like that consumptive system has been co-opted by substances. And so that's really where we're looking at this human behavior. And that's how we should look at comorbid use of nicotine and other substances as well. So what happens when people use more than one? Alcohol and tobacco are the most common. As you know, there's been a systematic societal head in the sand willingness to acknowledge that alcohol in and of itself is a carcinogen and accounts for a lot of cancers. And when you combine it with tobacco, it has a multiplicative effect on the risk of oropharyngeal cancers and also liver cancers and pancreatic cancers, and of course, dying from diseases like heart disease. Alcohol is one of the number one causes why people end up with atrial fibrillation, for example, or hemorrhagic strokes. And when you start adding that all together, alcohol and tobacco are really not a good combination. When you take a look at cannabis and co-use, especially now with the legalization of cannabis, we've seen this. People use tobacco and cannabis simultaneously. They either use it together by mixing, especially if they're using dried flower and they're not using they're not getting pre-rolls from a legal store. They make them into buds. They will put in loose leaf tobacco and get both. And that has implications for the treatment of both conditions. If people don't pay attention to it, they can misdiagnose the withdrawals from each. And then, of course, we also see it, and we see that in our patients here, is that they do a sequential. So they'll either have a cigarette first, have the joint, and then smoke, or they'll chase it, vice versa. So, but they're very closely related in time. And cannabis use has nearly doubled among patients seeking smoking cessation treatment, increasing from 20% in 2015 to about 37.7% in 2021. So the implications for smoking cessation programs is if you're not screening for co-use of cannabis, you're missing. And I think people should not make an assumption just because somebody's in their 50s or 60s that they aren't using cannabis. There are lots of people who are adults who are also using cannabis. And so every cessation program should be asking about cannabis use, including edibles, including vape pens. And that's something to really keep in mind, that people are using extracts as well as the loose leaf. When we take a look at the health effects of cannabis and co-use, you're beginning to see this effect. You've got a worsening of the dependence on both because now they condition each other. And then when people are trying to quit, the use of one increases the relapse to the other. And so often we're trying to get people to quit both simultaneously because they run together. Now, patients are not always ready to do both together, but ideally you want them to do both together. Of course, the respiratory symptoms, because you're inhaling, combustible tobacco. And what I tell people is, look, you're still getting a lot of products of combustion when you inhale joints. And so it's not as if, oh, this is a natural product, this is helpful. I try to remind people, like, tobacco is a natural product too. It's not medicine, and neither is cannabis. And so again, you'll end up getting this high exposure to carbon monoxide and etc. Of course, the other thing that happens is the impact on mood and personality and bipolar disorder, other issues that you'll end up seeing, including schizophrenia. So we really want to make sure that people understand that these impacts, especially on young brains, is quite detrimental. The number of people at times I've seen young people with anxiety disorders who are smoking cannabis now, THC now concentrations are like 28%, and now some people are getting fortified versions, which are then, infused with up to 35, 40% THC, and with the vape pen, 98%. You know, THC causes the anxiety, and often now, if you look at it, most people are getting high THC, low CBD. And that CBD, which is offset some of those impacts of THC, are now being sort of bred out and sold primarily as pure THC, which is not really good for people's brains. Now, the other group that we see are obviously high prevalence is those with opioid use and opioid use disorder. And this is opioid use, even if they don't have disorder and they have chronic pain, for example, and are using opioids. You get high co-use, and if they have opioid use disorder, it's like 80% are using. It's one of the highest substance use where you get co-use of tobacco. And it's much higher in the untreated individuals, getting close up to 95%. Of course, smoking accounts for a lot of the mortality in OUD patients versus non-smokers. So yes, overdose risks are there from the substance itself, but smoking is also an important factor, especially once people are coming into treatment and are on opiate agonist treatment. Smoking should be one of the first things we start helping them with, at least from a co-use perspective. Obviously, there's increased relapses to opioids and adverse neonatal outcomes in pregnancy when they're using both substances. And again, in pregnancy, it's really interesting. The smoking accounts for low birth weight. The opioids, not so much. So really, in pregnant populations, we really need to pay attention to both because we know the long-term effects that occur in the offspring are more likely associated to the smoking than to the opioid. And again, as we said, smoking exacerbates chronic pain, requiring high opioid doses. And one of our staff, Sabrina Verchi, has just published a paper recently around this from the STOP program. So bottom line is, if people are using tobacco, they're more likely to use other substances. If they're using other substances, they're more likely to be using tobacco and nicotine. And really, if you're working in the general population, you need to screen for both. If you're working in sort of specialized centers, we need to treat both simultaneously. But what happens to cessation outcomes? So when we take a look at the STOP program from 2023 to present, alcohol and substance use impact, if people meet criteria for alcohol use disorder, the cessation rate when these are self-reported cessation rate, 7-day point prevalence at 6 months, is a lot lower than those who use alcohol than those who don't. And with substance use, you're seeing a similar kind of outcome. So it's, you can see a dropping by about 5% or so. And again, we have an opportunity of intervening with both. So really, how do we make sure that we pay attention to the whole person and all they're doing rather than just one aspect of their addictions? Here's another study that we looked at the effect of alcohol use on the cessation treatment with NRT, and then higher levels of alcohol hazardous drinking, so it's a continuum, were associated with lower rates of smoking abstinence at 6 months, and you can compare your non-drinkers to low-risk drinkers. Really not a lot of difference if they're drinking a little bit, but based on the audit, which is a validated screening instrument, again, if you have you're starting to see a little bit with the mild, but the moderate, you're starting to see a drop, as well as with the heavy drinkers, the most drop. So this was just published in 2024, and you can see that this is Ontario data, obviously. So, and this is going to be really interesting as we start looking at the availability of alcohol going on, and a recent study that you may have seen from the CAMH monitor where fewer people are drinking overall, but those who are drinking more. And I guess that is an interesting thing about this concentration of risk among certain populations and how that happens. And we've seen that with tobacco as well, that current smokers are much more likely to be poor, less than high school education, and least able to afford the consequences of smoking. So as we looked at that, that's our local data. But if you look at systematic reviews, which naturalistic and experimental studies, alcohol use is linked to failed quit attempts. So, if we have smoking cessation programs that are not asking about people's alcohol and helping people stop the alcohol at the same time when they're quitting, we're going to get poorer outcomes. It's a quality issue. Shorter abstinence duration in heavy drinkers and alcohol exposure cues increases urges to smoke. So obviously we know this sort of common sense, right? But in studies have also shown, right? And that's why we'll hear from people that like hanging out at places where there's a lot of alcohol or seeing lots of alcohol or opportunities to alcohol, that leads to a lot more smoking. And we see that biologically as well. Alcohol disinhibits, it's conditioned to smoking, and people will tell us that they have real difficulty quitting smoking when they're drinking alcohol. How about cannabis? Here's Sabrina's paper we were talking about, again, coming from the STOP program. And when we take a look at about 83,000 people who were enrolled, cannabis use doubled from 2015, as we said. And that is clearly when you make something legal, consumption goes up. But also self-report of the activity could also be accounting for this increase because people are less likely of reporting a legal activity. But co-use, again, is associated with lower self-reported cigarette smoking at 6 months, 24% versus 29%. And even if you adjust for it, even though it weakens the association, it still remains. So therefore, we really must pay attention to both in co-users, not just one or the other. And people should make this informed decision about quitting both if they want to have a successful smoking cessation outcome. We know what happens is with cannabis use, it increases initiation. We're seeing now some of that reverse gateway happening in some communities, especially in young people, they think cannabis is less addictive, which it is, but it often is then predicting that they will continue to go on to adding tobacco into their mix. And so we need to start looking at this, that, how do we prevent people from starting with cannabis, going on to tobacco or vice versa? And then again, when people are trying to quit smoking, the withdrawal symptoms tend to be worse. You can see how it reinforces each as a smoke behavior. And so people will talk about one leading cravings for the other, and the synergistic effect of not being responsive to your environment and cues and using your ability to resist when you're kind of high on cannabis. So that little bit of disinhibition allows them to go back to use. Now, edibles may reduce co-use and smoking behavior, but on the other hand, edibles are not as harm reducing as you might think, because when you take an edible, it creates a metabolite that's about 7 times more potent than smoked. And the offset and onset is variable. So you never know if somebody says, I'm not getting anything, and starts having, 3 or 4 edibles. And now instead of having, 2 milligrams exposure of an edible, they've ended up having 20, and they get behind the wheel of a car or they fall or what have you. So it's not all, all safe. Edibles are not necessarily your best harm reduction option to smoke cannabis. It might be from the lung perspective, but not necessarily from an impairment perspective. So we really need to make sure that people have campaigns where you discourage mixing, and that is a critical piece. So then when we take a look at what happens, there is an evidence gap. Some studies have shown no impact on if people smoke cannabis. However, there have been no prospective studies evaluating the impact of cannabis severity on cessation outcomes. So like with the alcohol, where we saw like really, intermittent use of alcohol or non-problematic use of alcohol didn't seem to affect the quit outcomes. We don't have that. If somebody smokes a joint once every weekend, does that affect smoking outcome? We don't have those data. And we don't have biochemical verification of cannabis use because it persists so long in the body. We can't really tell when people have quit in the short term. And there's really no targeted recommendations for individuals co-using cannabis and tobacco. So really, we do need to have research that looks at this and clearly need to look at it, especially since the legalization of cannabis. What about coming back to OUD, the key outcomes and barriers? Here's the thing: people with Ontario with OUD, you get less than 8% success despite giving them pharmacotherapy. We also know that people who are using tobacco, their methadone dose tends to be higher, and then the methadone increase also increases cigarette consumption, and people have this really interesting balance between methadone dosing and their cigarettes and the cravings for cigarettes and how they use it. And so medication in general, you have about 1/4 the success rate of the general population. There are challenges of poor adherence, low self-efficacy, high stress, withdrawal symptoms. Often smoking is used as a coping mechanism during withdrawal. And what happens is, as we said, this dynamics, when the dose is kicking in, cigarette consumptions tend to go up, especially about 2 hours after the methadone dose. And then when the doses are going down at the end of the dosing schedule, at 24 hours, getting close, or somebody's being tapered off the opioids, you get a reduction in smoking when you get tapered off, but then you have a risk of relapse. So there's this fine balance of what can be done in people with OUD in terms of helping those people quit smoking, because once they're stable, their mortality is most likely going to happen from their smoking. So let's take a look now. Now that we know there's this issue around consumption and a co-use, and with these three common substances that we are using, we're going to look at concurrent versus sequential treatment of tobacco use in those with alcohol or other substance use disorders. So often we have to start with understanding how much, how frequently, and what is the pattern of use with tobacco. Most of our population surveys just give us an idea that they use, but we have no idea how they relate with each other. And this happens more in the clinical setting, where we understand which started first, how did they start, how did they move on. The other thing is, we often, in people with substance use disorders, one of the biggest issues is they will often come into treatment talking about a drug of choice. They'll say, my drug of choice is alcohol or cocaine or opioids or what have you. But when, as a clinician, you ask them, well, which one came first? They'll say tobacco. And then which one is the last to go? It'll be tobacco. So then when you ask them, well, really, your drug of choice is kind of tobacco, because you're holding on to that more than anything else. So when we find out, that's really important sort of information to find out, are they willing to give everything up together? Do they use it together? Does one trigger the other? So sometimes it used to be cocaine use, where people would find the cigarette burning and the ash burning as a trigger to use cocaine, or their cigarettes would be a trigger to have drink alcohol, or vice versa. So it's really important to know how these connect to each other and what happens to quit attempts. And often we will hear stories over and over again. Oh, I tried to quit. I quit everything, but then I went out, I had a drink, and the next thing you know, I was smoking again. And then again, relationship to thoughts, feelings, and behaviors. And often people will say to us, especially people with co-use, that they have a very strong relationship to cigarettes, because cigarettes have been with them throughout everything, through intoxication, through withdrawal, through being abandoned. Cigarettes have been with them no matter what else is going on with them, and they can always find a cigarette. Even if they pick it off the street, etc., they can always find it. So their attachment to cigarettes is really often, when you're talking to them, very personal. So yeah, we're going to look at some of the treatment options when people are co-using. Obviously, in our addiction management centers, which are only a small proportion of people go into, the withdrawal management settings, they need to be tobacco-free. And it doesn't matter whether they're specifically seeking tobacco use treatment. It's withdrawal management while they're there. So the staff have to be tobacco-free. The setting has to be tobacco-free, and they have to manage the withdrawal. And we can manage it with nicotine replacement, and it's safe to do so. So, for example, at the camp, there's always a concern when if you make withdrawal management centers tobacco-free, people won't show up. Well, the reality is actually they do better because now you're not, they're withdrawing and everything is getting managed at the same time. Uh, Obviously, the inpatient settings or residential treatment programs, we have McKay Manor in Ontario, which is a poster child that has, the staff went smoke-free. They all got themselves quit. They also all got trained and teach. And now they offer a program as an community addiction agency only on tobacco. So you can come into a community-based addiction recovery-oriented center that can help you quit tobacco if nothing else has worked. But they've also helped people who have been discharged from other programs and need ongoing support to stay tobacco-free in that setting as well as in an ambulatory way. And then the last way of co-use is taking a harm reducing approach to it. And you can take a look at Project Vector that's just got published and the lower risk nicotine use guidelines for people who are unable or unwilling to quit with the current evidence-based strategies. And I just saw somebody yesterday uh, who lives in poverty, has COPD, chronic pain, opioid use disorder, schizophrenia. We have tried everything, high dose clean nicotine, combination with varenicline. We've tried everything, and over 2 years. And this person has quit combustible tobacco for the first time in 3 months in their life for 3 months by switching over to a vaping device. 100% no cigarettes, no cravings, and from a quality of life, doing a lot better. So there are unique situations where harm reduction does make sense in this population when there's a lot of comorbidity and they're not benefiting from traditional treatment. So this continuum is required in substance use as well. So coming over next to cannabis and tobacco co-use, when we look at the efficacy of tobacco and cannabis interventions for co-users, when we take a look at 20 studies in a systematic review and a meta-analysis, the key findings are as such. There's weak evidence for in intervention efficacy. So typically these are CBT-based programming, behavioral program, because there's no pharmacotherapy for cannabis. There's been no clear effect on tobacco cessation. Generally, multi-substance interventions are more effective for cannabis cessation than just paying attention to cannabis alone. More likely, you're going to get cannabis reduction rather than cessation, but it does not affect tobacco reduction. So there is some feasibility and acceptability, but bottom line is, I mean, if I had to put this in a colloquial language, I would say despite the high prevalence, despite this, the evidence base is poor. It sucks. But really, we are really trying. We need to do better in having better behavioral treatments because there is no pharmacotherapy for cannabis. And yes, tobacco pharmacotherapy doesn't seem to work. What is potentially interesting is whether the new evidence for GLP-1 receptors, that could be potentially studied for substance use, and they are being studied, but whether they will have an impact on co-use is yet to be determined. So how do we practically approach it? One is we try to do it if people are open to doing both, if it's acceptable, and they're not going to go, I'm going to quit smoking and now, start using more cannabis, vice versa. We try to do it simultaneously. CBT is the most common. There are others, but they're hard to scale up. Medication, we use NRT as well, varenicline, and for cannabis, there's some very weak evidence for N-acetylcysteine. It's a natural product, you could get it, and cannabidiol for dual cessation, but really not widely used. And again, if you're going to do groups, we do it in person, remote, or hybrid up to 5 to 12 weeks. So this is emerging, and we're really working very closely with some of the cannabis researchers at CAMH to try to figure out how we can do a combined treatment. Okay. In this study where there is sequential and simultaneous treatment users. So you're treating one versus treating them both at the same time. One was immediate tobacco interventions from weeks 1 to 12, and then sequential is delayed tobacco interventions, and web-based counseling and NRT is given to all. The tobacco intervention was web-based counseling and NRT. So when you do simultaneous, 62% initiated counseling, 50% made quit attempts, 41% started NRT. Whereas when you went in a sequence where you delayed it, only 39% made quit attempts, 18% initiated NRT, and only 30% completed it. So simultaneous interventions support course cessation interventions, but do not affect the cannabis outcome. And if you're doing sequential, you need motivation-focused strategies to prevent dropout. So this is still jury's out, but really we're moving more and more. Let's do everything together because you can see more people will actually initiate their treatment for tobacco as well if you do it together. With alcohol and co-use treatment, there's been lots of studies in the past, and now you have this meta-analysis in 2021. Generally, varenicline shows significant short-term effect in co-use, and there was some mixed evidence that varenicline could work with people who use alcohol by itself, even if they don't smoke. But that's not been proven in well-conducted studies. But clearly, there is some evidence. The certainty is low, very low, that it does. But clearly, it can have an impact. Naltrexone, which is an opioid antagonist, it's the more powerful version of naloxone. You can take it by mouth and swallow it. It shows a lot of effect in alcohol, but does not affect smoking cessation. And the only role naltrexone has is in women who are quitting with nicotine replacement therapy. It affects actually post-cessation weight gain. They gain less weight, but no effect on smoking. So naltrexone has really fallen out of favor in the treatment of tobacco use disorder. But again, naltrexone has a role in the treatment of alcohol by itself. Topiramate lacks strong evidence for effects, and bupropion shows no significant impact on alcohol consumption, although it does impact smoking. So when you take a look at drugs that are typically for alcohol, they don't affect smoking as much, but varenicline and bupropion also don't affect alcohol as much. Varenicline is promising. But I don't know if anybody attended the Roberta France lectures yesterday that we hosted, where Christian Hendershot, Dr. Hendershot, presented on GLP-1 receptor agonists and his studies on impacts on alcohol consumption and tobacco consumption, and showing some really promising findings, but too early to make any definitive recommendations. When you look at effect of varenicline and patch on smoking cessation in heavy drinkers, this trial by King, when they were given varenicline and the patch, or placebo and the patch, you got higher abstinence in the varenicline group versus the placebo group, lower relapse risk, but it made no effect on alcohol consumption. So if people are heavy drinkers and are wanting to quit smoking, typically we're saying potentially take a combination varenicline and patch. I'm going to speak a little bit about GLP. I introduced you to that. So glucagon-like peptide receptor agonist. This is really an interesting, intriguing thing, been used mostly for weight loss and for diabetes management. But what was observed anecdotally was very interesting, is that people were reporting that they were reducing consumption of other substances, including nicotine, alcohol, stimulants. And it's not we're saying, why would that occur? Well, because both insulin and this GLPs are found in the brain and in the reward centers of the brain, and they seem to moderate how the brain processes reward. And so that is really important for us. And this has been old information in animal preclinical models, and it's now just more recently we're beginning to study it in humans. When you take a look at the systematic review, there's been a lot more systematic reviews than actual studies published. But in general, you're seeing an impact with the older ones. You're beginning to see reduction in heavy drinking days. You're seeing less drinks per week, fewer alcohol-related events. reduction in audit scores, and abstinence and reduced drinking as well. And so it is really an important, interesting thing that you may want to see this. Obviously, it seems to be affecting people more effective in those with obesity, but Dr. Hendershot is also seeing in people who are non-obese with lower doses of these medications. And so really there's a lot of interest in studying this and actually either proving or disproving that these could make a difference in co-use. Because of this emerging research that both Yemi and Lexfield have shown, that you're beginning to see reduction in consumption and reduced cravings and withdrawal. And really interestingly, from a public health perspective, reduced post-cessation weight gain by about 5.6 pounds. And that's really important that the dulaglutide, you got a very high cessation rate with the varenicline. So you didn't see any difference. So varenicline really did well in this population. But the post-cessation weight gain is really important because once people quit smoking, their risk, especially if they gain weight, of developing diabetes is very high. And it's different in men and women. And the duration of risk can continue for 5 to 10 years. So if we can actually prevent post-cessation weight gain and paying attention to the whole person, you can have a great impact. So that's smoking. But you can see how now we're potentially getting a single agent that can work for both tobacco, alcohol, and it's being tested. Can it work for other substances like cannabis, opioids, etc.? Like this one. For example, you look at this, and of course, there's an observational study, but this is where we often start. If people on semaglutide, which is now generic in Ontario, lower risk of opioid overdose versus if somebody was on other anti-diabetic agents. And so it's beginning to see that we need to start doing randomized controlled trials and that they're ongoing to see whether it can affect cravings and other consumptive behaviors. Okay, so that's a bit of the alcohol and that, and I'm going to make sure we get as fast as I can to opioid and tobacco co-use. Again, really the net here is contingency management works the best. That has the strongest effect. Interestingly enough, varenicline is giving people varenicline for the long term makes no difference. In fact, it's worse than combination NRT. And so our go-to with people who are on opioids, whether it's for opioid use disorder pain, is combination NRT. Its overall absolute cessation is low, but look at what it is with placebo. It's 2.2%. So we tend to go with a combination nicotine replacement, a short-acting and long-acting, and understanding that there's low adherence and there may be modest effects compared to the general population, but this is a population at high risk for all sorts of negative health effects. So, it is important to get them treatment for this. Naltrexone, as we said, no effects and really does not do it. So if anybody says that we're giving a naltrexone for somebody to quit smoking, it doesn't really do it. So that was a whirlwind, and I want to make sure we have some time for discussion. So how do I look at this? When we look at any addiction or excessive behavior or overconsumption, we need to understand that this has a common biological determinant that has to do with genetics, that has to do with the way the brain operates, the whole circuits that involve consumption. Almost all consumptive behavior have a reward system based into it. Almost all consumption behavior has a habit and a memory system built into it. And all consumptive behavior has a stress system built into it. That collective vulnerability comes into an environment that either promotes or protects the use and essentially promotes or inhibits that person from getting better from that consumption. And that's why when we take a look at tobacco control, the intersection between tobacco control policies like smoke-free places, taxation, availability, density, age, all these things interact with individuals at a population level, and people more or less respond to those things and have less consumptive behaviors. And we need to understand that similar factors at play as to why people drink so much or use cannabis so much or other opioids or drugs like that. And these shared vulnerabilities are why people use. And so when I look at somebody who is quitting smoking, I'm finding out about their co-use of other substances concurrently, their relationship with food, because often when people quit smoking, they're often compensating by increasing their consumption of food. And you see that when people stop other substances as well, they often will switch over to eating more carbohydrates, especially refined carbohydrates. So I look at them, co-use is essentially more common than not, and it negatively affects quit outcomes one for the other. I try to help promote concurrent treatment. I recommend concurrent treatment, and but if the person's not willing, really have sequential treatments as a way to get them to overall health, as opposed to one leaving just half treated. Try to use the best available evidence, approved interventions first, but then understanding that they need to be adapted to the individual, understanding there's many evidence gaps, but we can still help people. And then, where appropriate, adopt harm reduction strategies for those unable or unwilling to stop with traditional means. So I'll stop there. From a resource available to every Ontarian is Stop on the Net. And this is how they can join. There's a QR code. This is a kind of a population-based approach. Roughly on a good week, we've had up to 1,000 people enroll in Ontario. On a bad week, we've down to about 250. And we're really trying to make sure more and more people get to know about it. And so thank you for those of you on this call who have been promoting this to individuals, but we are realizing friends and families and other smokers are the biggest proponents of this, of passing it on. So we're trying to make sure that it's available to them to pass on. The Project Vector is the best evidence, which is in alignment with the Preventative Task Force evidence, is that for people who are unwilling or unable to quit with existing evidence-based treatments, how can they make an informed decision around vaping and e-cigarette toxicity? And then the recommendations that come, balancing benefits versus risk, given this unregulated market, recreational market, not unregulated, but a recreational market without a approved device. So thank you. You can reach me at my email, or if you're interested in any of the courses we offer, teach.chemh.ca, and we'll open it up for questions. So over to you, Selena.
Great. Thank you so much, Dr. Selby, for an amazing presentation. Tons of information. So if anyone has any questions, there's a few that have been posted. Please feel free to use the Q&A at the bottom of your screen. As I mentioned before, we'll do our best to get through as many as possible. And I'm going to post Dr. Selby's contact information in the chat that was posted at the end of the webinar in case we missed your question or you have something after. So Dr. Selby, one of the questions that I think is probably top of mind, so I'm going to start with like a very clinical one first, is so individuals that are working in settings and have very limited time and resources, what are some of the maybe tools or assessment questions that they can use that kind of captures this co-use or other substances? Because as you know, like for example, we've worked with dentists or dental hygienists, and they have like these brief contact interventions where there's the 5 A's or the 3 A's. So are there other strategies that maybe should be applied in those instances that we can kind of get a better picture, or should we be asking different questions?
Well, actually, the brief intervention literature is similar. It's like screening questions, so it's you use any of these substances, and then you can have a list of going through, there's something called the KH aid, which covers everything, and there's ways in which you can ask about all of those questions quickly. And very quickly, if you don't have time, you may say, okay, based on all of this, how they're related to each other, and are there things that you'd like to work on together, or are there things that you'd like to work on separately? And so, so those could be, I think when it's getting complex, that's when you have to start referring if somebody's using all those things. So the brief intervention, maybe ask and say, look, these can really affect your health for what you're seeing me for. So this can affect your lung health, your dental health, whatever. And I would like to make a referral to see somebody who can help you navigate through that. The problem is we don't have that well set up. Our addiction system is very separate from our tobacco system, is very separate from our health system. So it is something that we try to do here at CAMH and try to make sure that if people coming in with one will have that. And, that's what we try to do with the youth VAS program is because we knew youth who were coming in with vaping were also using other substances, who were also having other mental health conditions and things like that, or gaming and vice versa. So, that's really what we are trying to do there. So, and so if people come into our clinic for smoking cessation, we just don't ask about smoking. Even the stop program, we don't just ask about smoking. We screen about other substances. We screen for that. Because as you can see, this population does worse.
So to just pivot a bit to the youth piece. So for the earlier intervention for young people, would there be a slightly different strategy as well? So you have people working in schools, and again, they're applying brief
Yeah.
contact intervention. Like some of those are the ones that are referring to the Youth VAS program or
Yeah.
other CAMH programs. So are there potentially different conversations or tools that need to be used
Sure.
with young people to understand how other substances interact with their
Yeah.
vaping use or whatever nicotine product use they're using?
So I mean, I think we're talking from like first of all, I think we need to make sure that not an experiment continues to occur in all the schools. We need to make sure that the Prevention program, which is an evidence-based program, continues to operate in all the schools, and with that clearly in partnership with the youth wellness hubs, all of that continues. So if with youth VAS funding ending and being cut, I think one is, as I said, clearly we have always seen people within the nicotine dependence clinic, in my clinic, with young people who vape or smoke or what have you. The issue is that now we actually have to see them in person, at least for their first visit, because our physicians have to bill OHIP for that. Um, and we do have therapists on staff who could see them, but again, that remote option across the province we'll try to make sure that we continue, the STOP program continues to partner with youth-focused agencies. We're partnering with YHOOs. We're trying to figure out how others can access it. We have centers for youth like Dave Smith, who already collaborated with STOP. So we'll really try to make sure that we continue to make uh, resources available for kids who are who are dependent on vaping, so that who aren't able to stop on their own and or to get into the services. So and CAMH will continue to take referrals of people who are using multiple substances. They can come into the usual pattern. The issue is that it can't just be done all remotely like we had done with that program. So and I think it is something that we are going to have to continue to come together as a community of providers to see the lessons learned from Youth Vast, the resources that develop from Youth Vast, how they can be made available to youth and their families to use for, whether it's for gaming, for alcohol, vaping, other substances, that they can continue somehow. So, that's how I would answer that question for now.
Thank you. So just shifting like broader out to more public health lens. So you had mentioned about public health campaigns potentially discouraging mixing alcohol and
Yeah.
smoking could be helpful. Do you have any other suggestions or thoughts on um, what public health system or the public health could take a leadership role on, or where the best, I hate to say it, but like bang for our buck kind of thing, our return on
Well,
investment would be at this stage, knowing what we know right now?
so I think there are a few things. Knowledge about alcohol and cancer, especially breast cancer, needs to be not just the job of the Canadian Cancer Society, but all public health units and all public health. Secondly, the issue around public health campaigns, especially now that you've got uh, convenience store sales of alcohol who are also selling tobacco products. There's got to be some sort of that's an opportunity for intervention, knowledge, etc., and policy levers around this, a setting for co-sale of these two conditions that have two substances that actually, have a multiplicative health risk. So, those need to have big campaigns around it. And so I would say that that really needs to be one of those things. I mean, it's a smaller issue, but it is issue is the risk of fires when people are intoxicated and smoking, the cause of fire, creating fires. So again, from a fire prevention perspective, this is another public health area where, intoxicated people who smoke can be pretty dangerous to themselves and others. So, and when they do, it's really bad. So, that I think is another area of alcohol and smoking, people understanding this. And yeah, so that those would be some of like, top of mind ideas around that.
Yeah, I think there's
Okay.
definitely an opportunity around education and knowledge and awareness. So unfortunately, Peter, we've run out of time. So I just want to thank you again for presenting this great webinar. To everyone who hasn't had their question answered, please feel free to reach out to Peter and his team. I put the email addresses in the chat. They were also at the end of the webinar. Thank you to our events team behind the scenes that helped to support this live session. Thank you to you all for attending live today or those that are watching the recording in the future. Please keep an eye out for a survey. It's really helpful if you can take a few minutes to fill it out. It helps with our programming and planning in the future. And I hope you all have a great rest of your day. Thank you.
Great. Thank you. Thanks for this opportunity. Appreciate it.